Okay, good day everybody. I am Martin Utzurum, your instructor for today, and we are going to discuss in health assessment about assessment of the cardiovascular system. Are you all ready? Okay, if you are, then let's start. With the review and anatomy and physiology of the cardiovascular system, we should know about the heart sounds. The first heart sound is called S1. Please remember that. This marks the beginning of the systole and S2 marks the end of it. Okay, so now we have S2. Remember, the heart has two sounds, main sounds. It's the S1 and S2, that's the lub and the dub. Okay, results from the closure of the mitral and tricuspid valves that normally close within approximately 0.02 seconds or less. That's very, very slim, right? It's best heard at the apex of the heart or the lower left sternal border. Remember that, lower left sternal border, LLSB. The second heart sound, or otherwise known as S2, this is heard when the systolic pressure in the ventricles decreases below that of the aorta and pulmonary artery. The aortic and pulmonic valves close, producing the second sound, or S2. Clinically, this sound marks the end of the systole and the beginning of the diastole. For further information about this, I have added some videos that may supplement your imagination so that you can see and actually hear these sounds and better understand them. So please review the videos that I have attached. Now, we have extra heart sounds. Remember, we had two, right? We had two main sounds. Now this time, we have the extra heart sounds. These are the S3 and S4. Now S3 is a lilt or canter similar to the sound of a galloping horse. Like that, right? Galloping horse. It relates to a hemodynamic feeling or of a failing, non-compliant ventricle. This is a sign of CHF, okay? Congestive heart failure. The cadence sounds like lap da da, okay? Not lap da da. It's like that, lap da da, lap da da. Okay, next, moving on. Let's go to S4 gallop. If the atria have to contract against the ventricular resistance or decrease ventricular compliance, significant vibrations are generated, resulting in audible S4. This is a low-pitched sound occurring 0.08 to 0.2 seconds before S1, right before S1, okay? This may be associated with HTN, CAD, MI, and other abnormalities, which you will learn later on. Okay, and then there are also aortic and pulmonic stenosis and more. But our focus now is the normal heart sounds. Okay, the cadence sounds like la da dup, like that. Okay, that's it. The next is murmurs. I have also attached a few videos which are very extensive and very accurate, which best describes and make you hear the heart murmurs, the sounds. Okay, so also please review those videos. This is a series of audible prolonged sounds resulting from turbulence created within the vascular system. The heart sounds. There's a continuous murmur. This is generated whenever there is uninterrupted forward flow of blood from a high pressure system into one of low pressure, as in patent ductus arteriosus. Next is the venous hum. It's a turbulent flow within the venous system in the neck and superior vena cava. It's a continuous low-pitched sound. The quality is either blowing, rough, or somehow musical. That's the venous hum. Then we have the friction rub. Okay? It's like rubbing your hands together. A pericardial friction rub is a high-pitched, scratchy, leathery sound that is generated when the inflamed parietal and visceral pericardial layers rub together. It's associated with pericarditis, pericardial effusion, myocardial infarction, sharp knife-like chest pain may accompany the rub. Of course, there's friction, right? There could also be pain. Pain may radiate to the left shoulder and neck and aggravated with deep inspiration, coughing, swallowing, and position changes. Developmental, cultural, and ethnic variations. Now let's go to the infants in the context of infants. The foramen ovale that connected the right and left atria in the fetal circulation closes after birth, allowing the heart to function as a double pump. Okay, you can check out the picture above here. So you'll see the anatomy. Okay, and there are arrows that may show the flow of the blood. The ductus arteriosus, a shunt between the pulmonary trunk and the aorta, also closes shortly after birth. This may result in systolic murmurs until closure occurs within 48 hours. The normal heart rate for a newborn is 120 to 160 BPM or beats per minute. So this is a lot faster than our normal adult heart rate. Okay? And I'm sure you already know that, right? 60 to 100. Next, in pregnant women, the increase in cardiac workload often results in the development of a systolic murmur due to increased blood flow through the mammary artery occurring late in pregnancy or during lactation. As the pregnancy progresses and the diaphragm rises, the heart rises and rotates, displacing the apical impulse. The BP is usually lower during the first and second trimesters. Okay, this is the first 6 months. And the heart rate is slightly higher than in the non-pregnant state. For older adults, changes in blood pressure are frequently seen. Postural hypotension results from a decrease in baroreceptor response, decreased elasticity of the arteries, and the increased incidence of cardiovascular disease and medications. Osculatory gaps also frequently occur. These gaps are periods of silence after the first Korotkov sound. Okay, this is the true systolic, and subsequent Korotkov sounds, and may result in inaccurate BP readings. Okay, in performing cardiovascular assessment, what do? You ask the patient, right? You ask the patient, "Sir, ma'am, are you having a chest discomfort? If yes, when did it start?" You have to include that in your assessment. This is important because we need to know the history and when it started, and maybe early detection can lead to better intervention. What were you doing before the pain started? Did anything make it better or worse? Ask that. Also, you also ask this one. Have you ever had this pain before? What does it feel like? Where does it hurt? Then you must have the pain scale. You ask the patient or client. On a scale from 1 to 10, with 10 being the worst or the most painful, how severe is the pain? Okay, so you have to note this down, include it in your documentation. Health history. Do you have a history of cardiovascular disease? If yes, are you taking medications? If yes, again, what are you taking and why? Also take notes for that. Do you have any other medical problems? Are you having any breathing difficulties? Now we are assessing the cardiovascular system, right? Then you might be wondering, why are we asking about breathing difficulties? Now in CHF, there is breathing difficulty because there is abnormal production of fluids out of the cells which then leads to CHF, okay, or congestive heart failure. Then you also ask your patient, do you have any allergies? Then if yes, describe the reaction. You take notes for that, put it down in your nurse's notes, and then also in your assessment sheet. Okay, moving on. Together with the health history, we have to know the biographical data of the patient. Now, a quick review on this may identify actual or potential problems. Consider the patient's age, because the risk of cardiovascular disease increases with age. Of course naman, right? Gender is also a risk factor, with men having a greater incidence of cardiovascular disease than women. Women have a higher mortality rate within 1 year after a heart attack than men, or your MI, myocardial infarction. CAD also strikes women 10 years later than men. In addition, women who are having a heart attack often have different presenting symptoms than men. Besides chest pain, fatigue, and shortness in breath, they may also experience back pain, anorexia, and lightheadedness. Current health status. Now begin with the patient's chief complaint. Why they went to the hospital, to the clinic, okay? Why they complained. Begin with that always. Then keep in mind that the person with a cardiac problem may present with many symptoms or even asymptomatic. In others, symptoms that seem to be obvious cardiac origin may actually originate in another system, whereas symptoms that seem to be from another system may actually be in cardiac origin. Next, what are the common symptoms? In the chest, it may be cardiac, respiratory, gastrointestinal, musculoskeletal, or psychogenic in nature. Chest pain of cardiac nature is transmitted through the thoracic region by the 5 thoracic spinal nerves and may be referred to as to areas served by the cervical or lower thoracic segments. Also, these spinal nerves innervate the skin and the skeletal muscles. This explains the difficulty in determining the origin of chest pain and also explains the occurrence of cardiac chest pain in areas aside from the heart. Now, let's talk about palpitation. Now, I'm not talking about when you palpitate when you see your crush or whatever. When I say palpitations in the context of the cardiovascular system, a patient with palpitations has the sense that her or his heart is racing or skipping beats, right? Uy. Even when you drink coffee, no? Some people we palpitate. Now we have syncope. Syncopal attacks or dizziness are another symptom that may signal cardiovascular problems. These episodes can result from decreased cerebral blood flow. Okay? Edema. Edema may be seen with right-sided congestive heart failure and vascular disease. Edema may also result from an increased capillary hydrostatic pressure that shifts fluid from the capillaries to the tissues. Fatigue. I'm sure you're familiar with this one. Fatigue is a feeling of being tired and having no energy. To accurately assess fatigue, investigate changes in activities of daily living, or your ADLs, rest and sleep patterns, okay? Environmental factors as well. These may affect the fatigue of a patient. The common symptoms. Extremity changes. Symptoms such as paresthesia, numbness, tingling, okay, at the extremities. You know your extremities, right? Your arms and your legs. Now, there's coolness, and upon palpation, there's coolness and intermittent claudication. Pain. This is pain in the calves during ambulation. This may be associated with vascular disease, coronary heart disease, or cerebral vascular disease. Visible vascular changes in the extremities may be a clue that more extensive systemic vascular changes are occurring in the body. The common symptoms, what can we see, right? Or what can we feel? Sorry, what can we feel? These are the symptoms. Or the patient, what can the patient feel? Dyspnea and cough. This may also occur with the cardiac disease such as left-sided CHF. Dyspnea occurs from pulmonary congestion or increased pulmonary venous and capillary pressure. Okay? The purpose of the past health history is to help you identify factors in the patient's past that may have a direct link to his or her cardiovascular status. Or you may uncover risk factors that place your patient at risk for cardiovascular disease. Now you can base your NCPs here. The risks for ... Okay? So this can be a basis. Now going to family history. Now why do we need to study this, right? Why do we need to take notes? Why do we need to ask about it? The family history will help you identify familiar or genetically linked risk factors that predispose your patient to cardiovascular disease. Now we have your in your genogram, no, you can see there we can visibly write or illustrate this family history. Okay, if the parents have suffered from previous heart problems, then we write it down in our genogram. This can help us identify and prevent any cardiovascular problems later on. Now, the review of systems. This identifies problems in other systems that will directly affect the cardiovascular system and also help determine the effect and extent of cardiovascular disease on other body systems. Psychosocial profile. This enables you to examine the patient's lifestyle and identify risk factors for cardiovascular disease, essential in developing an effective plan of care. Chronic cardiovascular disease can also affect your patient's lifestyle, of course, forcing him or her to make changes to adapt to the illness. So no more too much activities, right? Just minimal activities and other interventions that we may require the patient to do, including the food, livelihood, ADLs. Anatomical landmarks. This is important. The heart is situated in the chest in the third, fourth, and fifth intercostal spaces to the left of the sternum. Okay? Basically, the heart is located at your left mid-clavicular line. Third, fourth, and fifth intercostal space. In a normal-sized heart, the right side is located more anteriorly, with only the tip of the left ventricle situated anteriorly. Right? It sounds so scientific, but if you are a little bit confused with this one, take a look at the videos and pictures that I have attached so that it will give you a visual, idea of where it is located. But I'm sure you know where your heart is. The sites for cardiac assessment: right base, aortic area; left base, pulmonic area. The Erb's point is at the third intercostal space, and your LLSB, tricuspid, and the apex is mitral. Okay? Left lower sternal border, LLSB, just in case you forgot. Okay, here it is. Anatomical landmarks. Everything that I mentioned is right there. Oh, sorry. It's right there. Okay? This is the heart right here. And this is the anatomical position. This is your sternum right here at the center. Okay? Slightly tilted to the left side. This is the left side. Okay? And everything there is labeled. So try to memorize this, because soon when you auscultate, you will have to find these points in the body. Now, this is your intercostal space right there. It's numbered 1, 2, 3, 4, 5. These are your intercostal space. Okay? As you can see here, at the right base is at the left left sternal border and right sternal border, second intercostal space. Okay? And let me show you. Yeah, this is the herbs point right there. Let me show you the apex. The apex of the heart is located at your fifth intercostal space, left mid. This is your clavicle. Left mid clavicular line, fifth intercostal space. That's where you find the apex of the heart. Your S1 right there. Your S2 can be best heard at these points. Okay, the right base and the left base. Moving on. So, when you see your patient, of course, you won't be able to see this, right? But you will see this. Your patient can be lying down or sitting down. You can see it this way. So this is where you find it somewhere. They say that S1 or the apex can be best heard somewhere below the nipple line. The nipple line. So somewhere here. But you have to count the intercostal space. You have to feel that. Okay? Next, the central artery and jugular veins. The carotid artery and interjugular vein run parallel to each other along the sternocleidomastoid muscle toward the sternal notch. The external jugular crosses the internal jugular and lies posterior to the sternocleidomastoid muscle. Here, the patient should be placed in a semi-Fowler's position, which is 45 degrees head raised. The carotid artery is located here, the red. Okay, arteries are colored red because there are oxygenated blood. When you say vein, they contain deoxygenated blood. So this is the internal jugular vein here. Behind it or underneath it or beside, okay, posterior to it is your external jugular vein. Here you have your angle of Louis and the right level of the right atrium. The approach. Perform the assessment in 3 positions: sitting up, supine position or lying down, and left lateral recumbent position. Placing the patient in several positions facilitates the auscultation of specific heart sounds. Work from the right side of your patient. It allows you to stretch the tubing of the stethoscope and minimize interference. Allay patients' anxiety by explaining that cardiovascular examination always takes time. But of course, it may take time, but also do your best to be more efficient with your time. Try to work as fast and accurately as you can. Be systemic in your approach. Okay, don't skip your points, the areas. You have to be systematic. The first assessment will serve as the baseline that will be used for subsequent assessments. The approach. Before you begin, of course, always wash your hands. Assemble needed equipment. Prepare a warm, quiet, private environment. Let your patient know that what you will be doing. Share your findings with your patient to validate them and provide ideal opportunity for patient teaching. The tools that you need. Equipment. Not equipments, okay? Equipment. Stethoscope, okay? Which has a diaphragm and a bell, of course. Sphygmomanometer. Scale, metric ruler, thermometer, marking pen, and of course, be vigilant, sharpen your senses. Okay. The general appearance in your book, okay, as you can see here, since we want you to learn, probably this is more like spoon feeding, but this is the picture, the portion of the book that you need to read. Okay, so you have to read this. If you want to read this more, click pause, read it, and then you may stop. Okay? The general appearance can give you important clues about the patient's cardiovascular status. You should take note of the following: age, weight, facial expression, posture or assumed position of comfort. Okay, this is important. If the patient leans forward and is sitting down, probably there's problem in the chest problem or problem breathing, right? How the patient dressing and grooming, if he's able to or she is able to take care of himself, then there's probably a little ease, okay? Less discomfort. The body structure, okay? Also, take note of muscle wasting. You know what muscle wasting is? Um, when cardiac and cachexia and muscle wasting on the upper arm. I'm sorry, I don't know how to really pronounce this. Cachexia. Yeah, and muscle wasting on the upper arms, thighs, and chest. So muscle wasting is there's weakness in muscle wasting. Okay. Now we have abnormal movements. Of course, rhythmic bobbing of the head simultaneous with the heartbeat. So that's called a Musset sign. Just read this, guys, please. Okay. Then we have inspection. When you say inspect, of course you look, right? It's a visual inspection. Inspect the great vessels in the neck and precordium for pulsations. To visualize external venous pulsations, look for the pulsation in the supraclavicular area. To visualize internal venous pulsations, look for pulsations in the suprasternal notch. Inspecting the carotid artery. Okay, if you really are having a hard time imagining, don't worry, just try to listen, because we have videos for this. So also review your videos so that you'll have a better understanding. Aside from getting the theory, okay, sometimes we learn visually. So also try to check out the videos if you really want to, grasp everything. So assessing the neck. Differentiate carotid arteries and jugular veins. Carotid arteries and internal jugular veins run parallel to the sternocleidomastoid muscle and the external sternocleidomastoid muscle, and the external jugular crosses the sternocleidomastoid muscle. Carotids have visible pulsations. Jugulars have undulated wave. Remember that. Carotids have palpable pulsations. Jugulars easily obliterated. Carotids not affected by respirations, and then jugulars are. Carotids are not affected by position. Jugulars normally only visible when the client is supine. Inspecting the carotid artery. Okay, abnormal findings. They are large, bounding visible pulsation in the neck at the suprasternal notch. Okay, these are signs of HCN, aortic stenosis, or aneurysm. Abnormal venous waveforms. These are giant A waveforms. Tricuspid stenosis, right ventricular hypertrophy, cor pulmonale, absent A wave, atrial fibrillation. Okay, next. Inspecting the carotid artery and jugular venous system. Measuring jugular venous pressure. Assessment techniques and normal variations. Position the client with the head of bed at 30 to 45 degree angle. That's low Fowlers to semi-Fowlers. No, just semi-Fowlers. Place a ruler vertically perpendicular to the chest at the angle of Louis. That's the sternal angle. Identify the highest level of the jugular vein pulsation if unable to see pulsations. Use the highest level of jugular vein distension. That is for your documentation, the highest level. Place another ruler horizontally to the point or at the point of the highest level of venous pulsation. Measure the distance up from the chest wall. Positive carotid pulsations, the JVP, is 2 centimeters at 45 degree angle. The jugular venous wave, okay, JVW, undulated, easily obliterated, varies with position change and respirations. Here, this is how you really do it. Inspecting the neck, You have your ruler here, and also you have to get the angle, okay? Because you have to take note of the angle. Remember that, at a 45-degree angle. Abnormal findings. There's elevated JVP. There's right-sided CHF, constricted pericarditis, tricuspid stenosis, or superior vena cava obstruction. And there is also low JVP or of course, hypovolemia happens. After hypovolemia, if it's not intervened, then of course you'll get the patient will go into hypovolemic shock, no, or MI, or any other very critical abnormalities, ailments. Inspecting the precordium. Now, you should look for pulsations in the precordium, paying particular attention to the apex area. The apex area. And then, positive pulsation at apex, may note slight pulsations over base in thin adults and children. Thin. Abnormal findings. Pulsations to the right sternum or at the epigastric or sternoclavicular areas, aortic aneurysm. Apical pulsation displaced toward axillary line. Left ventricular hypertrophy is noted. Okay. The neck. Palpating it. Palpating the carotid. Okay. Here, palpating the carotid. Lightly. Okay. Remember, lightly lang. Lightly palpate each carotid separately. Why lightly? Of course, that's an artery, guys. That's where the blood flows. So we do not want to constrict or restrict blood flow. Note the rate. Okay, rate, kapaspason, how fast. Rhythm, amplitude, contour, symmetry, elasticity, and thrills. Thrilling, yeah, thrills. The rate depends on the age. Okay. Of course, if the patient is older, it may be slower, but with a certain condition, it may be different also. So just take note of these. The rhythm should be regular, okay? Amplitude should be strong. +2 or +3 pulses may normally be seen in high output states such as exercise. If the patient did something physically, of course, there's +2 or +3. Contour, okay? Smooth, upstroke with smooth, less acute descent. Of course, it should be symmetrical on both sides. And there's elasticity. The carotid is soft and pliable. Palpating the neck. Now, palpating the jugulars. Palpate the jugular veins and neck and check direction of fill. Occluding under the jaw, the jugular should flatten, no? But the wave form will become more prominent. Occluding above the clavicle, the jugular normally extends while the jugular wave diminishes. Are you all right? Okay, just keep up, guys. Next, in palpating the neck, okay, we test the abdominal jugular reflux. Position the patient at a 45-degree angle. Place hands over the mid-abdominal area, as seen here in the picture. Okay? And then apply 20 to 30 millimeters of mercury of pressure for about 15 to 30 seconds. Press. Estimate the pressure by placing a partially inflated BB cuff on the abdomen under your hand. Then you'll know. Look at the jugular veins. While applying pressure, note increase vein distension and return to normal upon release of pressure. Negative abdominal jugular reflex. Okay? And there's jugulars are easily obliterated and fill appropriately. Mobalic na siya. Returns. Palpating the neck. What are the abnormal findings? Cardiac states above or faster than 100 beats per minute. That is sinus tachycardia, supraventricular tachycardia, paroxysmal, okay? Paroxysmal tachycardia, uncontrolled atrial fibrillation, ventricular tachycardia. The causes include CHF, no? Drugs such as atropine, nitrates, epinephrine, isoproterenol, nicotine, and caffeine, and hypercalcemia. Okay, these are the drugs for that, which cause that, which can cause that. Cardiac rates is less than 60 beats per minute. Oh, that's sinus bradycardia, heart block. The causes may include myocardial infarction. Okay, also drugs such as digoxin, quinidine, paracanamide, and beta-adrenergic inhibitors. Also, this is caused by causes hyperkalemia. So these are downers, guys. Okay, so we do not give this medication when the patient has a BPM of lower than 60. Not blood pressure, okay? Beats per minute. Irregular rhythm or is also called as arrhythmia. Unequal pulses is caused by obstruction or occlusion. There is stiff cord-like arteries, that is atherosclerosis. This is sclerosis. Atherosclerosis. This spelling is wrong, sorry. That's a typo right there. So it's stiff cord-like arteries. The arteries harden, that is atherosclerosis. Okay? Arteriosclerosis, in arteriosclerosis, there is the blockage or thinning, okay, of the arteries. Positive abdominal jugular reflex is there is right-sided CHF, tricuspid regurgitation, tricuspid stenosis, constrictive pericarditis, and cardiac tamponade, inferior vena cava obstruction, and hypervolemia right there. Palpating the precordium. Assessment and techniques. Identify and palpate each cardiac site for pulsations, thrusts, heaves, and thrills. Now, we have photographs here. There's 1, 2, 3, 4, 5 photographs. I want you to try and familiarize them because later in the slides, with the explanations, I want you to imagine that the apex is here, the tricuspid area is here, the base left is here, okay, pulmonic area, tricuspid. On the other side is your pulmonic area. Here is your aortic area and epigastric area. You know, where you usually feel pain pag mabutdan mugtiyan, no? When there is air, okay, in the abdomen, no? Kanang mabutdag tiyan, that's what we call it in our terms. Anyway, that's where that's where the epigastric area is. Okay, next. The apex, left ventricular area. PMI or LVI is 1 to 2 centimeters. Amplitude is small, duration non-sustained systolic. There are negative trills. Amplitude may normally be increased in high output states such as exercise. Apical pulsation may not always be palpable. Left lateral displacement of PMI may occur during the last trimester of pregnancy. LLSB may not be palpable, although small, non-sustained systolic impulse may be palpated, especially in thin patients. There are negative thrills. Epigastric area. There's positive, slight pulsation may be normal, no diffusion. Palpations not palpable at base left and the pulmonic area and the base right. The aortic area except in cases of thin patients. Now, how do we percuss the precordium? I'm sure you already know how to do percussion, right? Your plexor and pleximeter. Use indirect or mediate percussion to determine cardiac borders. Dullness at 3rd, 4th, and 5th intercostal spaces to the left of sternum. Okay? At the mid-clavicular line, sorry. Abnormal findings. Left sternal border extends to mid-axillary lines in an enlarged, dilated heart. In the neck, when we auscultate the vascular structures, you should have the client hold a breath, deep breath. So you tell the patient, ma'am, sir, can you please take a deep breath? Auscultate the carotid with the bell portion. Okay, remember the bell portion of the stethoscope for bruit. Some people pronounce this as brewy, but when you go back to your dictionary, it's brute. Okay, it's up to you, but brute is all right. Auscultate the jugulars with the bell portion of the stethoscope for venous hums. Of course, when you use the bell of the stethoscope, make sure that it is directed. Okay, the hole, you see it at the bell of the stethoscope, not the diaphragm. So you have to twist that portion of your stethoscope. Position the carotid bruit or the brute may be normal in children and is associated with high output states. In children, remember, they have higher BPMs, right? Pulse rates. So, of course, they will have high output states. Negative venous hums and positive venous hums may be normal in children. Only in children, okay? Now, brutes suggest carotid stenosis. Murmurs can also radiate up to the neck from the heart, as in aortic stenosis. Auscultating the precordium. See? This is using the bell here. This is using the diaphragm. Okay? It's not just turning it around. You have to hold this thing, the diaphragm part, and hold the tubing, the tubes, and then twist it. Okay? So that it can be the direction, the higher sensitivity can be changed from bell to diaphragm and diaphragm to bell. Tap it so that you'll know, listen, where the sound is, heard better. Diaphragm ba or bell. Next, auscultate the apex. This is the apex, right? Note rate rhythm, extra sounds, and murmurs. Auscultate at each site, every site, okay? Apex, LSB, urge point, base left, and base right. Note S1, S2, and the extra sounds or murmurs if heard. Listen at each site and with both bell and diaphragm. Okay? No shortcuts. I know it may take time, but accuracy is very important here. The apex. The rate depends on age. Okay? The rhythm, regular S1, S2, high-pitched systolic, short duration, extra sounds also. Physiological S1 and S4 may be heard in children and young and adults. And that's about it. So, guys, thank you for listening. I hope you learned something. If you have questions or whatever, you may send me a message. But I really encourage you, if you have questions in your mind, try to be independent, okay? Especially in this time of crisis and pandemic. I want you guys to research, and if you can, open your books if you have one, or search the internet, okay? And then find the answers of your inquiries, of your questions. That way you'll be independent, and you could learn also a lot. You can do not limit your learnings in the confines of the lecturer, me, okay? I want you to learn, because the world, and there's so much to learn about everything, especially in nursing. So thank you for listening. Take care, God bless, and study hard.